We're going to hear from Dorothy now and her heart journey and what brought her here today. Dorothy?
Hi. I'm 86 years old, and back in 2016, I started to notice I was getting pretty out of breath. Going up the stairs, by the time I got to the top, I wanted to crawl. And I thought, well, I'm pretty old for him to do anything about this one. I think it was about in April, I read in the Eau Claire paper, I believe the gentleman was from Eau Claire. He had this surgery done in Rochester. And I read it and I reread it and I thought, well, that's for me, but I guess I'm a little too old. So I never touched on it. I was at my doctor and he suggested that I should see a pulmonary doctor because I do have asthma. And so I went there, and from there on, my aorta was going into the critical stage. And I thought, oh boy, here we go. And I said, well, I don't know what we can do about that. And he said there is possibly something that could be done called the TAVR. And I thought, well, this will be interesting. I had a lot of second thoughts on it, but it was becoming where I was sitting in my recliner I shouldn't say most of the time, because probably every 5-10 minutes I was up doing something. And I could tell on my breathing, I thought, well, this is really bad. And so I went to the pulmonary doctor, and from there, they said if I qualify health-wise, they could do the surgery or the procedure. And I went through with it, and the test, I passed it, and Dr. Wiechmann and Dr. Calvin and nurses and more doctors. And I called my son and daughter, and I said, I think I will do it, but you better get up here. And they live in Illinois. And I said to Dr. Wiechmann, I said, yep, let's do it. I don't want to live this way. And we went through with it, of course, and I was home in 4 days. I've done real well. I try to space myself, but it's getting now that each day, each month, it's much better. I would have to rest once in a while, and I didn't really like that too well, but I did it because I had to. I couldn't go on. And I've been very, very happy with the results of this TAVR. It's really changed my life. The doctors were outstanding. The nurses were terrific. I just have nothing but thank you.
What you see in the upper left is a calcified aortic valve. On the right, you see the new valve over a balloon. So transcatheter valve replacement or transcatheter valve insertion, we call it TAVR. It should really be called, as our colleague Kevin Greason from Rochester tells us, it should really be called TAVE because it's really valve insertion, not valve replacement. Because unlike valve replacement surgery where you cut out the old valve and sew in a new one, in this transcatheter valve procedure, you're actually putting the new valve inside your calcified old valve. So here you can see the typical way this is done is we access the femoral artery and the valve, which is over a balloon, is passed up the aorta, and it's passed through the aortic arch, and it's positioned in the patient's aortic valve, and it's deployed. And it's dramatic. It's an hour of preparation, and Andy, what do you think? 2 minutes of pure panic, and then about 30 minutes of wow, that's cool. So this is, there are certain things that absolutely revolutionize medicine. And, beta blockers revolutionized medicine, and statins revolutionized medicine. Stent repair of abdominal or of aneurysms in the body has completely changed medicine. This is one of the biggest changes to medicine we've seen in the last, let's say, 5 or 6 years. You go from a sternotomy or a minimally invasive incision where you put a patient on bypass, you stop their heart, you open their heart, you take out the old valve, you sew in the new one, you close their heart, you take them off the heart-lung machine, you close their incision, you take them to the intensive care unit, to a procedure where you poke the artery, the femoral artery in the groin, you pass the catheter up the aorta, you inflate the valve in their old valve, and they walk out with a Band-Aid on their groin.
Oh.
I mean, it's unbelievable. Now, it's not for everybody, but it is an evolving science, and I think that in 10 or 15 or 20 years, it probably will be for everybody, or maybe for almost everybody. So this procedure 6 years ago was for high-risk patients only. It actually started out for non-surgical patients who were not a candidate for surgery. And then it was for high-risk surgical patients. It's now been FDA approved for moderate surgical risk patients. There's a trial in Rochester and several other large institutions in the country where they're now doing low-risk patients. So this is an evolving technology. It started out for only high-risk patients. It's now for moderate-risk patients, and it's unbelievable. And we're now actively participating in this technology at Mayo and Eau Claire. So this is fantastic, and it's exciting. And to talk about who is it for and who is it not for is a much longer conversation. But it is a railroad coming down the track.